The guest's disclosures can be found in the transcript.
Hello and welcome to JCO Articles Inside. I'm your host, Rohit Singh, and today we'll be discussing the JCO article, Back to the Drawing Board, Overcome Resistance to the PD-1 Blockade. And we are joined by the senior author of the article, Dr. Ticiana Leal. Dr. Leal is an associate professor in the Department of Hematology and Medical Oncology at Emory University School of Medicine, and she serves as Director of Thoracic Oncology Medical Program and Multidisciplinary Thoracic Oncology Leader at the Winship Cancer Institute. She also served as a member of the board of directors at the Georgia Society of Clinical Oncology. Dr. Leal, welcome to our podcast, and thank you for joining us.
Thank you, Rohit. Thank you for this interesting opportunity to discuss our editorial. My co-authors and I are very glad to be here today. So Dr. Jennifer Carlisle and Dr. Liu were co-authors with me on this editorial.
It's a really good article. And just for our audiences, the article, again, the title, Back to the Drawing Board, Overcome Resistance to PD-1 Blockade. It discusses the challenges and the potential strategies for overcoming resistance to immune checkpoint inhibitors in patients with non-small cell lung cancer. In this article, Dr. Leal and the colleague talk about the second line of drug when the patient develops disease progression while in immunotherapy, and they develop resistance and their definitions and what to do. So to Dr. Leal, can you please explain the mechanisms of primary and acquired resistance to immune checkpoint inhibitors in non-small cell lung cancer? I also saw in your article, you proposed the definition of immunotherapy resistance in solid tumors, distinguishing between primary resistance and acquired resistance. So if you can please share your thoughts and explain that mechanism.
So primary resistance and acquired resistance are related to tumor intrinsic and tumor extrinsic factors. And this is mainly clinically defined as of now, according to previous response patterns and timing of occurrence. And these definitions can be heterogeneous. And we certainly think that biologically they can be very different, and it can be different according to prior therapy, whether patients got immunotherapy as PD-1, PD-L1 inhibitor alone, or combination strategy with CTLA-4, or the combination with chemotherapy. But the patterns of resistance can be very different and can be based on defects in antigen presentation. It can also be due to tumor microenvironment immunosuppressive effects. And there are also additional inhibitory checkpoints that can be involved. The definition in terms of when to call it primary or acquired resistance at this point has really been based on consensus guidelines by SITC, by ESMO, as well as our group, LungMap, has developed clinical trials in this space. Specifically through LungMap, we've defined and incorporated the definition of acquired resistance as patients who have had prior exposure of 84 days or greater and then have had progression of their disease.
I can see why it's so challenging to come with a standard definition for immune checkpoint inhibitor resistance. And I think incorporating these definitions and predictive biomarkers for clinical trial design is going to be more important going forward. Your article talks about CONTACT-1 study. So can you please discuss the CONTACT-1 study and how the shifting treatment paradigm in the first line setting impacted it? And at the same time, also discuss the potential implications of the differential outcome observed between the men and women in the CONTACT-1 study.
CONTACT-1 was a much awaited study. The authors, Dr. Neal et al., looked at a very important question in the area of immunotherapy resistance. So CONTACT-1 was a randomized phase 3 global study that investigated the combination of cabozantinib plus atezolizumab versus docetaxel in patients previously treated with chemotherapy and immunotherapy. And as background, cabozantinib is an inhibitor of multiple receptor tyrosine kinases, including VEGFR2, MET, RET, and TAM family kinases. Preclinically, cabozantinib could lead to immunopermissive tumor microenvironment, and so it was rational to combine it with a PD-1 inhibitor. In early results of a phase 1b expanded cohort of COSMIC-021 showed really promising results of this combination, which led to the rationale of CONTACT-01. In this study, however, patients that were included had different prior treatment sequences. They could have had prior immunotherapy alone followed by chemo, or the opposite, or they could have had prior immunotherapy and then upon progression gotten combination of immunotherapy plus chemotherapy. That to say that immunotherapy re-challenge is something that people are doing in clinical practice, given the unmet need and the desire to overcome immunotherapy resistance. But perhaps that also includes a more resistant population of patients. And these patients certainly could have had heterogeneous mechanisms of resistance, which could have impacted these results. The study did not meet the primary endpoint of overall survival. We saw median overall survival of 10.7 months with the combination of atezo plus cabo and 10.5 months with docetaxel alone. In terms of the differences between sex that we saw in the CONTACT-01 study, just to kind of go back in terms of the preclinical studies that have been done, there have been some preclinical studies that demonstrated that perhaps there may be some biological differences in models of different genders in mice. However, in the clinical setting, there have been, I think, contradicting results. A meta-analysis showed that perhaps women derived less benefit than men. Other studies have shown that perhaps women have more adverse events to immunotherapy. In this study specifically, only about 20% of the patients enrolled were women, and the majority actually had non-squamous histology. And we saw here less benefit for immunotherapy in women. But again, I think the numbers here are quite small. This is an exploratory analysis. And I do think it highlights, though, the importance of making sure that we include populations and have higher rates of accrual, not only in women, but in other represented populations. In this study, only about 1% of the patients were Black.
Yeah. Thank you so much for highlighting those disparities. I think it's very important to making sure that we have proper representation of all the groups in our trials. I think based on just coming off the VEGF inhibitors, I think the lung map trial S1800A, it showed a significant improvement in median OS with the combination of pembrolizumab and ramucirumab compared to standard of care. Do you envision any future combination therapies targeting the VEGF pathway with immune checkpoint inhibitors in non-small cell lung cancer?
I definitely think that targeting VEGF with multi-kinase TKIs, based on the studies that we have seen, several now randomized phase 3 studies showing that this strategy is ineffective. So this has been quite disappointing, but we've now seen the results of CONTACT-1 that we're just discussing here, but also other studies, including SAPPHIRE, which was also randomized phase 3 that investigated nivolumab, plus another VEGF multi-kinase TKI, sitravatinib. And then we also saw LEAP-08, which was a negative study investigating lenvatinib plus pembrolizumab. There still is a question, though, whether you can target the VEGF pathway inhibition with a monoclonal antibody. So that's ramucirumab targeting VEGFR2 plus ICI, and whether that can actually be an effective strategy. In our lung map trial, the S1800A, this study was a randomized phase 2. Here we use the definition of acquired resistance of patients receiving prior immune checkpoint inhibitor for a minimum of 84 days, and they were randomized to the combination of pembrolizumab plus ramucirumab versus investigators' choice of standard of care, which did include docetaxel ramucirumab, docetaxel, gemcitabine, and pemetrexed. And this was a positive study. It led to significant improvement in median overall survival, and there weren't any significant safety signals here. And we're waiting for now the confirmatory study called the Pragmatica Lung Study.
Yeah, I did have one patient who raised sensitive pembro, and I utilized this combination and was able to see some responses. You mentioned Pragmatica trial. Can you provide more information about the ongoing Pragmatica trial and its potential impact on the treatment paradigm?
Yeah, the Pragmatica trial is an ongoing study, S2302. This is an effort that is ongoing. Dr. Karen Reckkamp is the chair of this study. And this is a study that actually has a very, I think, modern study design. The term Pragmatica, this is an effort that is supported by the NCI to really propose a clinical trial design that is pragmatic to promote diversity and inclusion in clinical trials. The aim of this trial specifically is to validate what we saw in terms of overall survival in S1800A. So in this study, patients with previously treated advanced non-small cell lung cancer are randomized 1-to-1 to the combination of pembrolizumab plus ramucirumab versus standard of care for patients previously treated with immunotherapy and chemotherapy for stage 4 recurrent non-small cell lung cancer. Primary endpoint here is overall survival. And I think this kind of highlights what we were talking about in terms of empowering investigators to treat patients in a clinical trial more so like a real world setting. And I think this can be paradigm changing and decrease barriers to enrollment and also include now the real world population that we see in clinical practice.
Yeah. Changing gears a little bit, I think your article also mentions other agents that have been tested in ICI-resistant setting, like lenvatinib, etc. However, those trials results have been disappointing. What are the possible reasons behind those disappointing results with multi-kinase inhibitors?
we saw some really interesting, promising overall survival results with these combinations in phase 2 setting. In the phase 1b expansion with Contact One, we saw prolonged overall survival that we thought would be promising enough to investigate in a phase 3. Ultimately, I don't know because there weren't any biomarkers that we could really tease out what was going on, again, to highlight that both in LEAP-08 as well as Contact One, there was no definition of immunotherapy resistance, which could have impacted. And we did choose the definition for Sapphire that patients had to have acquired resistance and immunotherapy had to be the most recent prior therapy. Ultimately, one potential reason for why these are not effective could be that this targeting with a multikinase TKI with multiple targets is ineffective, and you really have to target VEGF more precisely, which is the case here of ramucirumab, which targets VEGFR2. And whether there are differences between a TKI and a monoclonal antibody may also impact the outcomes here.
You mentioned like biomarkers. Do you think there are any other potential biomarkers beyond PD-1 or tumor mutation burden expression that can help us predict the response to immune checkpoint inhibitors, especially in non-small cell lung cancer?
I think that's a great question. I definitely think that more effort needs to be dedicated. And of course, there are multiple efforts in this direction. One of the challenges obviously has been to obtain tissue to do this biomarker testing in clinical trials. When you look at Contact-01, they did PD-L1 expression, but this was all based on archival tissue, and it was all based on sort of standard of care local testing. So a lot of heterogeneity there. And certainly using PD-L1 at baseline from initial diagnosis for a second line trial may have significant flaws there. Ultimately, right now for clinical practice, there isn't anything that's ready for prime time, but certainly it sounds like based on what we're seeing that combining biomarkers is more likely to improve the accuracy. And I think a single biomarker alone is probably going to have insufficient predictive capacity. It'd be great to be able to better comprehensively characterize an individual's tumor to individualize immunotherapy strategies in this relapse setting.
Yeah, definitely. We need more better biomarkers. Coming to your point of heterogeneous PD-L1, I myself had a patient when we got PD-L expression from one site, they gave us 1 to 49%. However, for the testing, I sent the patient to further lab at outside and PD-L turned out to be 80%, but that was from a different site because the biopsy. So yeah, to your point, it's very heterogeneous and definitely need to be more cautious in interpreting those. In that trial, in Contact One, we through the patient who have oncogene-edited lung cancer. Are there any plans to explore the role of immune checkpoint in oncogene-edited lung cancer, especially like non-EGFR, non-ALK? I know those are the ones that we have seen in multiple studies that they don't respond. But are the other oncogene-edited lung cancer, we are getting more and more target treatments coming out for non-small lung cancer?
Yeah, so for patients with driver mutations, the paradigm has been well established that if there is a driver mutation, patients should receive the appropriate targeted therapy. And immunotherapy as monotherapy has been ineffective in a lot of the patients with driver mutations beyond EGFR and ALK, certainly RET and HER2, ROS1, or other driver mutations that we believe that immunotherapy alone is ineffective. However, we are seeing some interesting ongoing clinical trials or completed clinical trials investigating immunotherapy in patients with driver mutations. Going back to the EGFR population, we recently saw the results of Harmony A, which investigated ivonescimab, which is a bispecific antibody hitting PD-1 and VEGF, that in combination with chemotherapy improved progression-free survival in patients with EGFR mutated non-squamous non-small cell lung cancer with progression on prior TKI treatment. So I think it is still an area of active investigation. And I do think that ongoing trials, perhaps with different PD-1, PD-L1 combination strategies, such as bispecifics, may be interesting, but does require investigation.
Yeah, definitely. It looks like combination therapy is going to be the most likely answer coming forward. With more research, we're able to figure out the best possible treatment in this subgroup of patients. Considering the current challenges and ongoing research efforts, how do you see the field of non-small cell treatment evolving in coming years?
This is an interesting and important question. I think it's been really exciting to be working in thoracic oncology research. We have seen that these research efforts have led to advancement in the field. I think we need to continue to partner and collaborate with institutions, partner with industry, and also with patients and patient advocates to design clinical trials that are really going to focus on the needs of our patients in clinical trials. The gap in second line and beyond after immunotherapy failure is a significant one. So I do think that the challenges are to continue to develop biomarkers to really understand who will benefit from immunotherapy strategies, who benefits from combinations, and most importantly, who does not. I think biomarkers are going to be something that we need to continue to incorporate in clinical trials. And I do think that there's a lot of room for hope and promise in the field. We've seen some interesting results with antibody drug conjugates, and the combinations there may also be of interest. And then other important strategies, we're looking at T-cell engagers and different drugs with different mechanism of actions, including CAR-T and vaccines. So beyond immune checkpoint inhibitors, I think we have different classes of drugs that may lead to different treatment strategies for patients in second line and beyond.
Yeah, certainly we have seen such extensive development in lung cancer. However, there's still a lot to be done, as you just mentioned. Thank you so much, Dr. Leal, for your time and great insights discussing the article with us.
Thank you.
Thank you for listening to JCO Article Insights. Don't forget to give us a rating or review, and be sure to subscribe so you never miss an episode. You'll find all ASCO shows at asco.org/podcast.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.